Hello, so my name is Becky Matthew, and it is great to be here again for the third and final webinar in this series that we have been doing. The first one, we really took a look at what we call leaky brake disorders or disorders of disinhibition. Our second webinar really focused on some of those emotion regulation strategies and ways to support youth with leaky brakes in their different environments. And today I'll really be focusing on the specific treatment for some of the different leaky brakes. And so if your child, or if you're asking, like, what do I do if my child does have Tourette syndrome or a tic disorder or pediatric OCD or body-focused repetitive behaviors, which I'll be introducing in a moment. I hope at the end of this, we'll have a really clear pathway in how to access those specific treatment services through the Brake Shop at CPRI. So again, my name is Becky Matthew. I'm a community behavior consultant with the Brake Shop Clinic at the Child and Parent Resource Institute in London. And I'm just going to go ahead and share my screen and hope that all goes well. Okay, so I'm counting on Ashlyn to let me know if things are not working or sound is malfunctioning. But I'm just going to jump right in due to time here. And so I really want to start off with introducing, because we haven't spent a lot of time in the last couple of seminars really talking about these disorders that fall under the umbrella of body-focused repetitive behaviors. So the two main disorders under these body-focused repetitive behaviors, or BFRBs, would be what we call trichotillomania, which is where somebody pulls out their hair, or excoriation, which is skin picking, which are two really of those main ones. But we also see some other ones that include cheek or lip biting or nail biting. When it comes to these disorders, there's very specific diagnostic criteria that a doctor would be looking at in terms of diagnosing these behaviors. And it would be things like recurrent hair pulling or skin picking, resulting in hair loss or lesions, repeated attempts to decrease or stop the behavior, but they're unable to, causes clinically significant distress or impairment, and it's not better explained by another medical condition or mental disorder or use of a substance. I'm actually going to take the time here and just show a video that does a really nice job describing some of these different disorders.
Body-focused repetitive disorders is an umbrella term in the DSM-5, or Diagnostic and Statistical Manual, the 5th edition, for disorders where people compulsively damage their physical appearance. In fact, these used to be classified as impulse control disorders, but now they belong in the family of obsessive-compulsive disorders. Two of the well-known ones are trichotillomania, which is a hair-pulling disorder, and excoriation, which is a skin-picking disorder. Obsessive-compulsive disorders are usually defined by psychological obsessions, which are thoughts, urges, and images that are unwanted, intrusive, and recurrent, as well as behavioral compulsions, like repetitive behaviors that are in response to the obsessions. For body-focused repetitive disorders, though, the self-damaging behavior is typically not related to a conscious psychological obsession, but instead it happens when a person feels stressed, anxious, or even bored. And once a person starts the self-damaging behavior, there's usually a strong urge to keep doing it over and over again. This can happen in multiple short episodes throughout the day, or during single, long sessions that can last hours at a time. People with body-focused repetitive disorders aren't always fully aware of their behavior while they're doing it, and this makes it difficult to stop the behavior. Also, these behaviors are distinct from behaviors that improve physical appearance, like plucking the eyebrows, and are not attributable to underlying causes like substance abuse. For example, skin picking, which is a side effect of amphetamine or cocaine use. Also, behaviors from other mental disorders, for example, skin picking as a result of tactile hallucination, which could be like seeing or thinking there are bugs under your skin. Also, behaviors from other medical conditions, for example, scratching at the skin due to a scabies infection, or finally as a side effect of a medication. Trichotillomania is one type of body-focused repetitive disorder, where people feel an irresistible urge to pull out their hair, resulting in hair loss, which comes as no surprise. Now, here the name defines the condition. Trick derives from the Greek word for hair, tilo is related to the Greek phrase to pull, and mania refers to frenzy. This hair pulling can happen in any part of the body, but the most common sites are the scalp, the eyebrows, and the eyelids. Because the hair pulling sites can vary slightly each time, trichotillomania is not always as visible as you might think it is. Having said that, the most common area for hair pulling is the scalp, especially the hair around the crown of the head, which can result in a very distinctive pattern of hair loss referred to as a friar tuck appearance. People with trichotillomania generally feel embarrassed by their behavior, and often make repeated attempts to stop or hide it. Sometimes this hair pulling can be associated with specific ritual behaviors, like only pulling out hairs in a specific way, like with tweezers or with the root still intact. Regardless of how this is done, as the behavior continues, it can lead to permanent damage of the underlying skin and future hair growth. Excoriation disorder is another type of body-focused repetitive disorder, which used to go by the name dermatillomania, derma referring to the Greek word for skin, and the same Greek roots that relate to the term to pull, and frenzy. So these people feel an irresistible urge to pick at their skin, often resulting in skin lesions, most commonly on the face, the hands, and the arms. Some people pick at healthy skin, whereas others pick at minor skin irregularities like damaged nail cuticles, pimples, dry skin, and often scabs from previous picking. Picking is generally done with the fingernails, although some people even use their teeth or tweezers. These behaviors often lead to embarrassment, and like trichotillomania, people often try to stop the behavior or to do it privately. Unfortunately, chronic damage to the skin can cause scarring and infection. Now, there are a number of other body-focused repetitive disorders that are less common, like trichophagia and dermatophagia, which is where people compulsively eat their hair and skin, respectively. Often these disorders happen alongside trichotillomania and excoriation, where people eat the hair or skin that they pull and pick. Dermatophagia might involve picking or biting the inside of the mouth, the cheeks, and the lips, which can lead to sores in the mouth and an increased risk of infection. Often dermatophagia appears along with onychophagia, which is chronic nail biting, where people bite their nails and the skin around their fingers, as well as onychotillomania, which is nail picking, which can lead to bleeding and scarring. The common features shared among all these disorders is that the symptoms cause significant distress and impairment in social functioning, and that people often make numerous unsuccessful attempts to stop the behavior. Typically, these behaviors start around puberty and can be associated with conditions that often develop around that time as well, like acne. Body-focused repetitive disorders are chronic conditions, although people can sometimes go into remission for months or even years. That said, there are treatment options available. For example, medications like tricyclic antidepressants and selective serotonin reuptake inhibitors have both been useful in reducing these behaviors. And those medications are most successful when they're paired with some sort of therapy, like habit reversal therapy and cognitive behavioral therapy. In both of these cases, people are trained to identify and differentially react to the impulse that leads to the repetitive behavior. Alright, as a quick recap, body-focused repetitive disorders are part of a family of obsessive-compulsive disorders, and are where people compulsively damage their physical appearance. Two of the most common ones are trichotillomania, or hair pulling, and excoriation, or skin picking. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling.
Okay. So again, lots of really great information in there, really kind of talking about those different disorders. And because BFRBs are so frequently misunderstood, and we find that there's even few health professionals that have had training or knowledge specifically in treating the BFRBs. I know initially there was often a lot of youth that would come to the Break Shop Clinic and we would use a little bit of the habit reversal training from the tic management, and a little bit of the exposure therapy from the OCD, but it didn't quite fully meet their needs, which caused us to embark on the better understanding and training to become certified in the treatment of BFRBs to really support these youth that were struggling in these different areas. A lot of what we do is education because it is one that is very misunderstood, and one that there tends to be a lot of shame associated with, which I'll speak about a little bit more in a moment. But we really start to break down a lot of those facts and myths that we find are pretty common when it comes to any of the BFRBs, whether it's the trichotillomania or the skin picking. Things that we do know about BFRBs is that the age of onset typically is in adolescence. However, it can actually occur at any age. There's even examples of baby trich. So it can be quite young, but what we typically see is in that age of adolescence. And one fact that we really start to drive home is that BFRBs are in fact very common. At one point, it was thought that they were quite rare, and a lot of people that do struggle with BFRBs feel very isolated. That they didn't even know there was a name for it. But when we really got into looking at the statistics, it's basically 1 to 2% of the general population suffer from trich or excoriation. But this is actually considered to be a significant underestimate because there's probably a lot of people that are not reporting it due to that shame and embarrassment, or many people that don't seek treatment because they're not aware that treatment even exists for it. Behavioral interventions are the first line in treatment. There's no specific medication to target the BFRBs, but there's often medications that can help some of those co-occurring diagnoses, for example, anxiety or OCD or some of the other things that they may be struggling with as well. And one of the myths is that, BFRBs are harmless, that it's no big deal. When in fact we know that it can actually lead to permanent hair loss, infections, scarring, injury. There can be different social implications or mental health implications with that. And what they spoke about briefly when they talked about the trichophagia, which is the ingesting of the hair, can actually be very dangerous and sometimes even fatal. So that is one of the questions that we ask immediately when we find, that kids do have trichotillomania, is making sure that they are not ingesting their hair for that reason. Some other myths is that, BFRBs only affect females when in fact, the male to female ratio can be quite, actually almost the same, but men can more easily mask a lot of the symptoms. So again, maybe more underrated in males. It's more, socially acceptable for a male to shave his head maybe than a female. And so they may be attempting to either mask or deal with symptoms that way. Other myths are that BFRBs are a result of trauma, though they can absolutely co-occur. It's not a cause and effect. So it's not that all people with a BFRB has suffered trauma, but that doesn't mean that there's some that don't. And I'll talk a little bit about kind of understanding that entire model of BFRBs. BFRBs are not a form of self-harm. In fact, they're not trying to hurt themselves. And some actually find the behavior quite soothing and satisfying, and not necessarily an attempt to replace emotional pain with a physical pain or numbing. And one of the biggest myths is that people can stop if they want to. Many of the people that I work with, they've been told to just stop it. And if it was that easy, they certainly would have, because they're often the ones that struggle the most and would like to stop if they could. So why the Bright Shop? Why did our clinic embark on, becoming certified in this treatment and developing a treatment for youth and adolescents? Well, as you can see, there is a very large co-occurrence and overlap between a lot of the other leaky break disorders that we treat within the Break Shop. You can see for those that have the trichotillomania, the hair pulling, 2 to 9% of people with tic disorder or Tourette syndrome may have trich, or 8 to 16% of those with ADHD. And we get higher in those numbers with the OCD. And you can see either both under the trich and the excoriation, it can be upwards of 68% of those with excoriation also have an OCD diagnosis. BFRBs were initially under the umbrella of OCDs, and we heard kind of the different professionals saying it is an obsessive compulsive disorder. It's not. It is not. It falls under its own umbrella now of the body focused repetitive behavior, because as we learn more, we can start to make some of those differentiations there. But there is definitely a high co-occurrence with Tourette syndrome and tic disorders, ADHD, anxiety, and some of those different mood disorders as well. So a large part of the treatment when youth come to us with this either a query of the diagnosis or the diagnosis is that we really do a very thorough assessment, and a functional assessment is also completed. But this is really when we start to look at, are there more than one behavior? You may have skin picking and hair pulling. You may have just one or the other. Maybe there's some nail biting or nail picking as well as hair pulling. So really finding out what are the different BFRBs that they may have. What are the different sites that they pick or they pull from on their body? When was this behavior first started? Were there any stressful, significant events or triggers? Strategies that they've tried, if they've been effective or not. We start to look at this sequence, what comes first, what happens next, and some of those social functional impairments, and an intensity assessment of the damage that may be done. And so we use different measures and scales to determine those things for both. So the treatment component. So if we're thinking, okay, I think my child or this child that I know or I work with may have a BFRB, or it's been determined they have a BFRB, what does treatment of these BFRBs look like? And so these are some of the different components that we use within our treatments as well. And so again, heavy on the psychoeducation, educating not only the child, but those that are supporting the child and even those that may be around them, whether it's extended family members, school, anybody that is available for that learning. And then a very thorough functional assessment, tracking, and awareness training is completed with the youth. We do self-esteem building and boosting because we do know that this diagnosis tends to carry a high level of shame. And then we introduce strategies. We use this STEP model, which I'm going to talk about in a little bit more detail, which has been adapted from the COMB model. And again, we'll look at what each of those components to the STEP model look like, as well as that relapse prevention as we come to the end of treatment. So it's really important to look at the data that we gather, and we do that mainly through tracking, because this really starts to promote a higher awareness, and we really start to take a look at what was going on at the time that this picking or pulling occurred. How much time did we spend on that? Was there an urge prior? How strong was that urge? What strategies did you try? Were they helpful? And so this really helps us, and we gather this information, we complete the tracking throughout the entire duration of the treatment, so we can start to see if there's been any improvements or change in any of the picking or pulling that occurs. And then from that tracking and gathering of information and the functional assessment that we complete, each child gets their own individualized model created to help them understand their specific pulling or picking profile, because no two people are the same or have those same reasons, even though there may be similarities and crossover. It is very personalized. The reasons that are contributing to the BFRBs, therefore, the strategies need to be personalized as well to really make sure they're the most effective for that client. So again, we really take a look at, and when we look at this model of BFRBs too, it really helps us understand why they can't just stop. If it was that easy, it would be great, but here's all the parts that are contributing and impacting that would make that incredibly difficult to do that. So we take a look at some of the biological vulnerabilities or some of the different leaky break disorders they might have. If you remember in previous slides, we looked at all those co-occurrences. So they may have some of those other leaky breaks, whether it's the OCD, the anxiety, the Tourette syndrome, or tic disorder. They may have a family member who had difficulty with hair pulling or skin picking. So it's kind of in the genes, so to speak, or they may be wired to do that. There's differences in the brain that may make them more likely to develop this disorder. They may have some impulse control disorder, which would really make it difficult to stop certain behaviors. So again, when we take a look at that, there can be a whole host of those biological vulnerabilities that come with that. And if it leads to that hair pulling or the skin picking, which we talked about commonly starts in childhood or adolescence, there's two ways that the hair pulling is maintained or the skin picking is maintained, what kind of keeps it going. And that is through positive reinforcement and negative reinforcement. So with the positive reinforcement, for many, the hair pulling doesn't actually hurt. They will describe that it feels good to them. Or there's many aspects of the pulling that may be pleasurable or have a ritual that's pleasurable afterwards. For example, they may pull their hair and then kind of run the hair along their skin or their hands, and that's just very calming and soothing. So they get that positive, that reinforcement there. Some may enjoy the sound of the pop that it might make if they pull out their hair, or when they get a really good piece of skin kind of pulled off. So there's that kind of positive reinforcement that is occurring at that point. Or there's the negative reinforcement, and that would be where for many, the hair pulling or the skin picking helps to take away some of those bad feelings. So it might decrease the stress or the worry or depression or boredom, or even help tolerate some good feelings like high excitement. It can help with that. And many will report that it's triggered by a negative event or a spike in a worry. So they're using it more as that coping strategy. So you have this positive reinforcement, you have this negative reinforcement, and that is a very powerful connection that will keep that BFRB going. And because of those two things, it makes BFRBs extremely hard to stop. Then we take a look at some of the different triggers that may be involved. And again, there's many different types of triggers that people may experience. It could be anything from internal and external triggers. So you might have the internal emotions that we talked about: boredom, stress, worry, excitement. Any of those types of things could be a trigger, or even different places or postures, or things like looking in the mirror, going into the bathroom might trigger some type of BFRB behavior, or the posture and how I sit. If I'm sitting on the couch with leaning my head up against my hand, and pretty soon my hand's right there and I've started to engage in either the skin picking or the hair pulling. There could be for some specific thoughts that, well, it has to be even. So I picked on this side or pulled on this side, so I have to pull on the other side. Or all hair has to look the exact same. Or if there's one that feels different or wrong or more coarse, it must come out. Or I deserve this, I've had a rough day. So there can be a lot of thoughts that can be triggering for the BFRB, or the different emotions that we've talked about, or arousal levels like being tired or bored, or some will say they actually use it as kind of a soothing bedtime routine. So we've got these positive and negative consequences there. We've got the internal and external triggers, or reinforcements. We've got the internal and external triggers, which can then lead to different consequences for some. So some might have a low self-esteem, be incredibly embarrassed. Some might have hair loss. They might have, scarring, or changes how you look, might take a lot longer to get ready, might not be able to do certain activities because if some are working really hard to hide bald spots, maybe they're not going outside on windy days, or they're avoiding swimming pools, or things that might make some of those things more noticeable. Or as we discussed, it could even lead to different health problems. So we look at this whole model, and we do these very specifically for each child based on the tracking and the functional assessment that we complete with each one of them, to really help them understand their specific model and all those parts that are keeping it going. When we start to talk about, the shame and the blame, many blame themselves, or they've been told they could stop if they just wanted to, or it's their fault, they're choosing to do it. They should just be able to stop. We really start to look at that. We'll say, well, we wouldn't ask somebody, what was the day you woke up and decided to have asthma? or diabetes, right? So this wasn't a choice. So if you look back to that model, there was a lot of things that contributed to that. And so we really take a look at, kind of love to look at this, don't confuse your who with your do. The BFRB is the things that you're doing. That's the things that we're doing. That's one part of you, but who you are is made up of some incredible characteristics, and that's the essence of who you are. The BFRB is what you do, but there's so much more to you than that, and we really spend a lot of time looking at that. We even look at, our BFRB Book of Fame that has different famous people that also have endorsed having BFRBs. So it's anywhere from Justin Timberlake to Megan Fox, and so it can really be helpful for the youth that we work with to see that they're not alone in that, and then sometimes that is actually quite powerful for themselves as well. So this STEP model that we talk about, that we focus on in the treatment is, as you can see, the sensory, thoughts, emotions, place, and posture. And so if we're looking at that sensory, understanding our sensory systems, so the sensory distraction, sensory diet, self-regulation. In here we look at competing response. The thoughts are some of those, what we call tricky or picky thoughts that might be keeping that BFRB going, and we learn how to replace them. We put some of those thoughts on trial and gather evidence for and against the thought. We work on developing coping keychains with coping helpful thoughts for them to take with them to help replace those thoughts. Under the emotions, we really focus on emotion regulation, relaxation strategies, some of the please skills that are adapted from the DBT treatment. So looking at our physical being, illness, eating, things that we're avoiding, sleep, exercise, all those things that just help with well-being and different coping strategies. And again, the P is recognizing how places and postures can act as triggers and learning how to prevent those. So really looking at what we call stimulus control strategies. So the place and posture, or the stimulus control strategies, would really be any of those strategies that would make it more difficult to engage in that picking or pulling. So for example, if I constantly pick up my toenails or pick up my fingernails, then maybe putting on a pair of socks or wearing gloves when I'm triggered would make it more difficult to engage in that. And we actually have an extensive checklist that they can go through, keeping fidgets in their hand or putting on those little, I think they're called finger pots, or they look like thimbles, on their fingers that would make it more difficult to engage in that picking or pulling, or putting band-aids over the spots that they might pick or pull from, or even dimming the lights. If someone is very focused on looking in the mirror and searching and grazing for that place to pull or pick from, then maybe keeping the lights off or dimmed when they go into that place where that typically happens can again make it more difficult to engage in that. Or if they are using tweezers or pins or safety pins or scissors to assist with that, then just getting rid of those altogether. So there's lots of different ways, finger traps, band-aids, lots of different things that can help that would make it more difficult to engage in that picking or pulling. When we look at that sensory, this is where we're looking at not only a competing response, but a sensory diet. For those that really engage in the picking or pulling, because it's meeting some of that sensory need that need to fidget or pull or that popping or different things, we work with our occupational therapists to understand our sensory profile and some of those things, whether we're sensory seekers or avoiders, and ways to replace some of that just in our daily activities to make sure that our sensory system is staying balanced throughout the day. And then we look at that competing response. One thing I didn't highlight in the model was that our picking and pulling can either be very focused or unfocused. So that might mean some are very aware of when this picking and pulling is occurring. They might even be going and looking in the mirror. They might be scanning with their fingers to look for the hair or the skin that they want to pick or pull. Where others may have been engaging in the picking or pulling and not even realized it until they're bleeding or somebody else points that out. And so again, maybe if it's unfocused, different people will use jingly bracelets. So when their hand comes up, they can hear the jingle and that alerts them they're about to engage in the picking or pulling, or some scents on their wrist so they can smell it as they come up. Just some of those cues to bring it to their awareness. But the competing response strategies are strategies that you do instead of the picking or the pulling. And so there's 3 rules that lead to a good competing response. And that is, it must be incompatible with the picking or pulling, meaning if I'm engaging in this competing response, I can't be picking or pulling at the same time. It must be easy to do in most situations, and it doesn't cause more embarrassment. It's also something that they need to be able to do for at least 1 minute or until the urge passes, whichever one is longer. So again, we have an extensive checklist that they're able to go through. Maybe it's specific sensory items. Maybe they're picking out a cork or eraser instead of picking out their skin. Maybe they're pulling the bristles off of a paintbrush instead of pulling hair. It could be they're sitting on their hands or putting them in their pocket or crossing their arms and tucking their hands, up under their armpits. Or some will use elastic bands. Some will use this as a sensory or a stimulus control strategy, keep their hands busy, play with it. Or others will even use it to kind of wrap around and make it more difficult to engage in that picking or pulling. So it's really about finding the strategy that works for them, because it's going to be very different depending on the youth. And you can just see some different ideas on there, peeling the orange and then peeling all the white kind of stringy stuff off the orange. Some youth have really found that helpful and effective. Holding a book with both hands, taking glue and putting on their hand, letting it dry, and then peeling the glue rather than peeling their skin. And again, knitting, crocheting, doing art, things that keeps both of their hands busy can be very helpful. I mentioned that we talk about addressing some of those tricky, picky thoughts. So that maladaptive thinking that leads to or allows that picking or pulling to continue. And we really take a look at those thoughts and we start to replace those thoughts. That falls in line with what we call the neuroplasticity. We will see a video a little bit later in this presentation around that. But really kind of asking ourselves the question, is it helpful? Is this thought true? Is it logical, realistic, rational? Based on what evidence is this thought even true? And we will take their thoughts and we set up the room like a courthouse and we put it on trial. They dress up as a judge, they've got the gavel. Again, everything tailored to age appropriateness, but really taking a look at what's all the evidence that says this thought is true and what says this evidence may in fact not be true. And we weigh that out at the end and say, is this a tricky, picky thought? And if so, should we send that packing? And we do that by replacing it with a more positive one. And then under the emotion, so we really look at those relaxation and regulation skills. So we do things like deep diaphragmatic breathing, progressive muscle relaxation, different visualization or grounding techniques. And then depending on their age as well, for some of our teens or older youth, we also add in this idea of the acceptance or tolerating the urge, which is, again, adapted from the DBT or ACT therapy, but it's really just recognizing that they can, in fact, handle the urge. It's kind of like a wave coming and going. Don't need to try to block it. We don't want to judge it, get rid of it, or push it away or hold on to it, because sometimes it's a response to the urge that's worse than the urge itself. So really starting to recognize that we can handle the distress that sometimes comes with that urge. And they each get different tools. So they have these little tool cards so that they can keep them handy. They have little cards, advocacy cards that they can hand out to whether it's schools or waiters or waitresses or extended family members, coaches, bus drivers, whoever it's helpful, that really talks about some of the things that people might notice about having this leaky break or this body focused repetitive behavior. On the one side of the card, it talks about some of the challenges that they might notice or that people might see. And you can choose to see that side of me, and you flip it over, so you can choose to see the other side of me, which is some of those really positive characteristics that they've come up with in terms of understanding that who they are. So that's kind of understanding the body focused repetitive behavior, specific diagnostic criteria. This is what a treatment would typically look like. I'll talk about some of the different treatment criteria a little bit later in the presentation for each of these treatments within our clinic, but that is just a brief overview of what treatment would look like if a youth was embarking on that with us. want to talk now too about what the treatment is for Tourette syndrome. In previous webinars, I went through kind of that detail of understanding some of that diagnostic criteria of a tic disorder, or that what we call the leaky breaks over our movements and sounds. So I mentioned in those previous webinars, I'll just touch on it briefly now, is really this idea of when we see or hear the tic, that's the second part. Preceding that movement or that sound is what we call the premonitory urge, which is present in about 80 to 93% of all cases of tics or Tourette syndrome. Younger kids may have a harder time recognizing or reporting on that premonitory urge, and may more often perceive those really complex tics. But it's really that urge, that feeling that I must do this tic, that precedes the tic. And without the urge, there would actually be no tic. Some may describe it as having an itch, a pressure, a heat, a tickle. And the more they try to hold it in, the more it can actually increase that sensation or that urge. And they eliminate the urge by engaging in the tic. So kind of like that mosquito bite. I get the urge, that's like the itch. Oh, that feeling, I must do it, I must do it. I scratch the mosquito bite or I do the tic. Oh, momentary relief. Because if you think about the mosquito bite, when we scratch that mosquito bite, may feel good for a moment, but then we must keep scratching and it can get itchier and itchier. And it's because of that it negatively reinforces that tic. We've now made that connection in the brain. When the urge is present, I must tic in order to relieve that sensation. And the longer one suppresses or tries to hold in that tic, the worse it feels. So we say, suppression in and of itself isn't bad, but really want to take a look at what's the cost to the suppression, because it takes a lot of physical and mental energy to be able to engage in suppression. And so when a youth is doing that, it makes it much more difficult to, listen to the lesson that might be being taught at school, participate in the activity around them. And they've described it kind of like having this permanent poison ivy or being covered in mosquito bites that you just can't scratch. So you can imagine if you had that sensation, just how uncomfortable that would be. When we start to take a look at the habit reversal training, that is part of the gold standard treatment for Tourette syndrome or tic disorders, what we're going to see is that they've renamed it and added parts to it that are really effective when it comes to the treatment of these tics. And one thing they discovered is the environment can influence tics without causing tics. So some will say, as soon as I walk into the classroom, I start to tic, because maybe they're thinking, don't tic, don't tic, don't tic, don't tic. The more we think about it, the more we're doing it, or certain places can impact that, but that classroom didn't cause tics, so it could be that the environment is influencing it without causing it. So again, as I mentioned, it was renamed to Comprehensive Behavioral Intervention for Tics, CBIT for short. We just call it tic management in the break shop, but this is the gold standard treatment for anybody that has Tourette syndrome or a tic disorder. Again, this is just some of you wanting to look up the research and really understand kind of where this came from. There were many different studies that were completed in order to determine this treatment. What they did find with CBIT was the equivalent efficacy to medication. And there was actually a low relapse compared to those that just had medication. And there was no adverse events or side effects that came because of the CBIT. And then again, the Canadian guidelines for the evidence-based treatment of tic disorders. Oops, got too far there. Okay, so what does the treatment or the CBIT, Comprehensive Behavioral Intervention for Tics, what does the treatment include? And so there's really 6 main components to the CBIT that I'm going to chat about in a little bit more detail. There is psychoeducation, self-awareness, tic analysis, relaxation training, competing response training, and social support. So if you look at the psychoeducation, this is, again, another really important component to not only educate the youth or the teen or the child that has the tics, but those around them. Because if we think about kind of reinforcing that tic, maybe the youth has been watching TV with the family and they're and they're being told to go get a Kleenex or stop that, you're interrupting, it's being loud. And the more attention we give the ticks, the more that tick hangs on. We're inadvertently kind of making that tick a little bit worse, a little bit bigger. So it's really about understanding and that the child is not doing this on purpose. If anything, they're more distressed than anybody else regarding some of these different ticks. And then we really look at that self-awareness. So the self-awareness is really breaking down. We do a lot of detective work to really understand a specific tick. We track every single one of their ticks, so we get a good list of what their ticks are. But then they choose one that they're going to start to work on, that we really start to focus our attention on starting to block and then hopefully eliminate. But really starting to understand what is that premonitory urge. That is a really crucial component to understanding that tick. And we do different things like we play catch the urge or catch the tick. So just as we're sitting here in conversation, anytime they feel the urge to tick, they put their finger up. So we really need to build on this awareness so that when it comes time to teaching them the competing response, they know when and how to use them. So as I mentioned, we list all their ticks. We don't try to target all their ticks at once because that would be overwhelming for everyone, but we do list their ticks and track how bothersome each of those ticks were from week to week. They might give the tick a name, my sneezy tick or head jerk tick or whatever that might be. And then we pick what they call their target tick. So the one tick, and it's always the tick that bothers the child the most is the one. So they really need to be motivated to work on this. Doing tick blocking is incredibly hard work, especially in the beginning. So the more bothersome the tick, the higher the motivation is to try to get rid of that tick. And so again, we start to focus on the tick analysis. So we pick the tick and we start to get all the different ways in which that tick looks. So we start what happens first at the urge, then what happens, what part is moving. If it's a vocal tick, we talk about tongue placement and what do our lips look like? Are we breathing in, breathing out? Or, if it's a motor tick, what body part is moving first in what direction? Is anything else tensing? So again, we really do this thorough tick analysis of that tick treatment before we even start to embark on the competing response. When we're looking at the tick, the good thing is ticks aren't very creative. They come out at the same time every time. And so we really look at those warning signs that your body is giving before they come out. And knowing exactly when the tick is about to happen or is happening is a very, very important part of the treatment. Because if they want to learn how to manage something, they first must know when it's actually occurring. Okay, and then you see there too the relaxation training. Ticks are often exacerbated by stress and anxiety. A lot of our youth explain, when they get really stressed out, they've got exams, they've got transitions, they've got a quiet classroom they're about to go into, anxiety goes up, and ticks typically are increased with that stress and anxiety. So we really do a lot of focus too on that relaxation training, very similar to the BFRBs. So doing that deep diaphragmatic breathing, the progressive muscle relaxation, that's often one that is really helpful and effective for youth with tics because they say it actually calms their body down because at the place of the tic, it can be very painful at times. It might be very tense. And so the progressive muscle relaxation, as I talked about in a previous webinar, kind of brings that muscle to a more tense state and relaxing that. So that's been one that a lot of our youth and clients have said have been quite effective for them. Some of the different relaxation strategies, as I mentioned, was the breathing, the progressive muscle relaxation, even some grounding techniques and some of those distress tolerance strategies can be really helpful in just, again, calming that situation when they're starting to feel anxious, because again, the more anxious they feel, the more their tics may come out. And we talk about how not all stress is bad stress. Maybe you're really excited about an upcoming birthday party or different things, and sometimes we see the tics come out more with that as well. So really just starting to understand those different things that can trigger and exacerbate tics. And then we move into the competing response. Again, very similar to a competing response that we talked about in the body focused repetitive behavior treatment. But we know that the more you do a tic, the stronger it gets. So the less we do the tic, the weaker it gets. So the only reason the tic is occurring is to satisfy the urge. Without the urge, there'd be no need to tic. And so our goal is to actually get rid of the urge, because if they don't have the urge, then they don't have the tic. So it's not necessarily targeting the tic, we want to target that premonitory urge. And so again, we start to find that thing that is incompatible with the tic, meaning you can't do both at the same time. If my tic is to raise my shoulders up, well, if I'm holding my shoulders down, I can't do both of those at the exact same time. And so we're finding that thing that is the opposite to the tic, or incompatible for that. It can't be worse than the tic. So, the opposite might be standing up, spinning around and yodeling, but that's probably gonna be worse than the tic that we're doing. So that's not gonna be an effective competing response. And it has to be something that, again, you can hold for 1 minute or until the urge passes, whichever is longer. And so some will say for some of those vocal tics, well, just hold my breath. Well, what if that urge is still there 2.5 minutes later? Can you hold your breath that long? Probably not. So we need to find a different competing response that matches all three of those guidelines for the tic, or for the competing response. Okay. What I want to chat about here too is, again, I touched on a little bit in the BFRB, but this is that idea of that neuroplasticity. So the idea of being able to rewire the brain. And so we do that in so many of our different treatments, whether we're treating anxiety and using cognitive behavior therapy, whether we're doing something different in the tic management, we're starting to create new pathways in the brain, whether it's doing a different thought or a different behavior starts to increase that. And this is just a really great short video that we share and can actually bring a lot of hope to a lot of the youth, saying, okay, so I'm not doomed to do this forever, that it is possible to learn some skills, even if it's something that I've had, or a tic that I've had that's been quite entrenched for a long time. So I'm just going to share this video.
Not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-travelled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep travelling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
I mean, what great news for us, for any of us, if we're trying something new or trying to change a habit or do something different, but especially for those youth that are embarking on these different treatments, especially when it's really, really difficult. And Again, I'm doing kind of a brief overview of what these different gold standard treatments for these specific diagnoses look like, but we really break it down, and it's basically one topic per week. So we spend a lot of time on each of these things, really learning, really educating each of the youth and their families, whether it's individualized treatment or in a group format. Okay, so when do they use their competing response? So the competing response is anytime they feel that urge. So the moment they feel that premonitory urge, kind of like that itch that comes before the mosquito bite, that's when they want to start to use their competing response. We're not waiting for the tick to show up, to come out, to hear it or see it. As soon as we feel that urge, because remember, our goal is to starve that urge. If the tick can't come out, then the urge has no reason to be there anymore. Or if a tick slips out. So maybe a tick got past them. We kind of think about, like, we're starting off tick blocking. If you think about like a goalie, their job is to block those pucks that are coming at them. And so when we're first starting that tick blocking, our goal is to kind of block some of those ticks that are trying to come out. And there might be some that slip out, but that's okay, because as soon as that tick comes out, block it as soon as one slips out, because that may stop any kind of tick burst or ticks that follow that initial tick. Or if they're in what we call a tick hangout. So if you know, every time you go to sit down and play video games, or you go into math class, or you sit on the couch, or you're around a certain person and the tick tends to come out more, start practicing your tick blocker in those environments as well. So when the urge is present, if a tick slips out, and when they're in one of those tick hangouts or those tick eliciting situations. And those are the three I just mentioned. Okay, what can often happen is kids get into this and think, oh my goodness, it's getting worse. I was doing well, and now it feels like the tick is there, and we reassure them that is absolutely normal, part of the change. We kind of talk about, how ticks will start to throw a temper tantrum. They're used to coming out. Whenever that urge is there and wants to come out, it comes out, and now we're stopping and blocking it. So imagine if you kind of took candy from a baby, what are they going to do? Or a child, they're probably going to have a little bit of a temper tantrum. The tick is going to do the same thing. Expect first victory to take about 4 days to a week to really be able to get a good handle on that tick. And then you might see that it starts to spike up again. We call that the spontaneous recovery. And again, it's very normal and expected part of CBIT. And as they go, it can probably take up to 3 months to reach complete extinction of the ticks. But it's not uncommon for their kids to say that. They say, they work so hard. They say the first week or two is the hardest. You're putting a lot of attention, a lot of time, a lot of energy into blocking that tick. But as you can see, as that goes, it takes less effort, less time to block those ticks. And within 3 months, most of them have reached extinction of that particular tick. And then they have the tools to be able to choose the next tick and start on that one and be able to apply those same tools and techniques for the ticks that are bothersome for them. Okay, some things that we've learned as we go, watching those stimulant levels, being aware of med changes. If we're kind of in a time where they're doing a lot of medication changes, may not be the best time to embark on treatment, because that will make it a little bit more difficult for the youth. We want to start at a low stress time if possible. So some will say start on the weekend, summer holidays, March break, or just a time like maybe not right in the middle of exams or a high stress time. We probably don't want to be starting our treatment during that time. And when we're starting to block those ticks, we start as soon as we wake up. We don't let the tick come out and decide around noon or 3 o'clock we're going to start blocking that tick, because by then it's gotten nice and strong up until that point. So from the moment you wake up until you go to sleep, we take that one target tick that we're working on and really apply that tick blocker. And we only do one tick at a time. A lot of our youth have multiple ticks, some that don't bother them at all, and we wouldn't even focus on those ones at all, but some may have several ticks that are quite bothersome. But we wouldn't focus on all of this at once. It would be incredibly overwhelming. Fill the beaker, if you remember that analogy from the previous webinar. So we really take a look at one at a time. And we know that it can take a lot of time. I like this quote, my goal is to be as good as I can be, not to be good in a hurry. And that can be the hardest part, because it is such hard work and it does take time. That can sometimes be a difficult challenge for some of the youth and even some of the family members that would like to see the ticks eliminated quicker. And then we really work with that kind of social support and the adults around them, whether it's parents, schools, teachers, grandparents, coaches, really like teaching those skills on how to be a really good cheerleader. We're actually praising the effort, not the outcome. So are we seeing them really practicing their competing response, even if that tick is still sneaking out? And then we're providing prompts and reminders to use the competing response rather than don't tick, don't do that, stop. We're reminding them of the strategies that they have on hand, but then ultimately it's up to the person with the tics to actually engage in the treatment. So this is one of those treatments that's really heavy on they have to complete that. We can't do it to them or for them. Okay, it's CBIT is not suppression or tick replacement or like pushing water uphill, but it's actually counter conditioning. So if you think back to that neuroplasticity, creating that new pathway in the brain and kind of redirecting that current. And so treatment and CBIT is appropriate when it is their desire to stop a tick. Sometimes kids will come and say, my tics don't bother me. I actually kind of like them. Cool. We're not going to do anything about those tics. We're not going to change that. But if you have a tic that bothers you or is painful or interfering, then certainly we want to be able to help with that. Or maybe they've been a little bit medication resistant and that any meds that they've tried haven't actually touched those tics at all or made any kind of an improvement. Or that philosophically opposed, so they see some of those positive traits about leaky brakes. So again, they're not coming at it from a place of shame, but there might be some of the tics that bother them, and those are the ones that we focus on. I'm going to talk a little bit in a few minutes about the specific criteria for these different treatments, but they do have to have that cognitive availability or ability of at least age 8. It's not, CBIT wouldn't be an appropriate intervention if we're looking for a really quick response, because as I said, it does take time and effort. And if the treatment needs to be prioritized elsewhere, first we may start with something else. Maybe we're treating the OCD or treating the ADHD before we are treating the tics. If they're a little bit too leaky, sometimes because of that ADHD or leaky brakes over attention and impulses, maybe we are treating that first so that they can maximize their treatment in CBIT. Again, looking at that combination of meds and CBIT. So we often say pills don't teach skills, but it can provide that scaffolding that's required to be able to learn the different strategies in the treatment. And again, it might not be appropriate if it's, others driven. So the tics are bothering other people, but not them, or it's other people's attitudes or reactions to their tics, in which case it becomes more of an intervention of education and really helping people around the youth understand it better. On our website, leakybrakes.ca, if you click on the virtual toolbox, the tick management, there's lots of teaching videos, lots of our strategies right on there. Again, I'll talk about that a little bit more. And again, some strategy documents that can be shared with family members, schools, and anybody that it would be helpful to have that information. And it's Dr. Duncan McKinley, who's a creator of the Brake Shop, is in each of those different videos. The last one I want to chat about is just the treatment of OCD, or as we learned, that leaky brake over our thoughts. And the gold standard treatment for OCD is what they call exposure and response prevention. And what they have discovered with the ERP is that it actually creates identical neurochemical changes as Prozac. So you really see that efficacy in this treatment of the ERP. ERP targets the obsessions, not the compulsions, and the goal is to actually reduce the anxiety that is surrounding the different thoughts. And we do that by developing a very specific toolkit. I'm going to go through each of the different tools that they would be learning in the exposure and response prevention. We learn how to map out OCD because some of the areas of OCD might be much more distressing than others. So we learn to identify which ones are kind of in the child's territory, what ones might be in what we call the work zone. So we can start working on some of those through exposure assignments, and some that would be just a little bit too tough to start, what we call kind of OCD territory to start. So we'd be looking at ways to break that down. We introduce the tools, and we really work on specific exposure trials and assignments every single week. We know that avoidance is bad. The more we avoid something, the harder it gets, the smaller our world gets, and the bigger our anxiety gets. And so when we are avoiding certain things, if OCD says, I can't touch that, or I can't say that, or I can't think that, or I can't do that, it really just starts to reinforce that compulsion. They don't learn that mastery is in fact possible. And again, we talk about it really starts to make some of those anxious thoughts bigger. And you could follow every single one of OCD's rules, and his appetite would still not be satisfied. There'd be one more thing that you need to do, one more thing. So again, the anxiety gets bigger and their world can sometimes get smaller because of that. And so we really take a look at this kind of vicious cycle of avoidance. We see, so especially as we start to embark on some of the exposure, we know we are now as ego dystonic. We are kind of doing something that is kind of forcing some of that anxiety. We're going against what OCD says needs to happen. And so as they're starting to take those steps, they start to ride this worry hill. We use a lot of information from Oreen Pinter-Wagner, and this is one of Dr. Wagner's slides that we really find helpful in really just kind of describing what happens when we give in to OCD and we don't make it up over that panic peak. If we are engaging in that compulsion every time we feel that anxiety rise, then our anxiety, yes, does go down quickly, but again, it's momentary, kind of like the tick and the scratch of the mosquito bite. It may feel good for a moment, but we have not habituated. We have not recognized that what OCD is saying is not true, and we don't actually have to engage in the compulsion in order for that anxiety to come down, because what they haven't yet learned is that their anxiety can only go so high. The only thing OCD can do is raise your anxiety, can't actually make anything bad happen, and that feeling would go away even if they didn't engage in what OCD was telling them to do. But the more that they can do that, so when they face that fear and they make it up over that hill, the next time they do it, they feel less anxious and it takes less time to get up over the hill. By the time they are doing that same step, maybe 20 times, by the 20th time, it's boring, ready to move on to the next step because now they've mastered that step. So we go step by step by step as we're creating these exposure assignments. Okay, I'm just gonna do, how am I doing for time here? Okay.
Hi out there, my name is Christine. So, my friends call me a germaphobe. I hate germs and feeling dirty. I get so grossed out touching stuff, like I won't touch the poles on the bus, or I even use my sleeves to open the doors. I know it looks weird, but I just imagine all the germs and gross stuff that could be all over them. As soon as I get home, I have to wash my hands, and I change out of my school clothes and put on clean clothes. Dirty ones go right in the laundry. I can't relax until I feel clean. Nothing from outside can come into my room. I leave my purse, my backpack, and jacket by the door. My dad gives me a hard time because I won't eat anything with my hands. I even use a spoon to eat chips. I'm just really scared that I can get sick and die if I catch something. You can never be too careful. My friends tease me about it and say stop being so OCD, and my mom says I should see a psychologist. So, I have been for a month. He's helping me toss back my OCD.
So that clip too is from the Anxiety Canada website, which is a really fantastic resource for anxiety type strategies, lots of videos specifically to OCD, to certain phobias, anxiety, social anxieties, generalized anxiety. So it is a wonderful resource if anybody is interested in looking at more videos on the different varieties of the anxiety disorders. And as I mentioned, we know that confronting anxiety is a good thing because it does allow that habituation to occur. We start to realize what OCD is saying isn't true. Nothing bad happened. Things are okay. I don't actually have to follow OCD's rules. It's like calling OCD's bluff. And as I mentioned, as you see, each time they practice a step of exposure, the easier that step gets. until they are able to master that area. So it's pretty neat to see kids that have really avoided or engaged in all kinds of rituals to boss back OCD, to see them getting freedom in that area and to not be bound to the rules and rituals that OCD says that they have to follow. I'm sorry, I am going a little bit quicker through because I'm seeing the time, but these videos and understanding the different tools that I'm going to be talking about in a moment, they're all on our website with a video clip for each of the different tools, so you can have an understanding of what these different tools are. But a really important part of the exposure and response prevention is first understanding their OCD, mapping out their specific obsessions and compulsions, and from there starting to build their toolkit, because these are the tools that they're going to need to use in order to start bossing back OCD. And when I say bossing back OCD, I mean embarking on some of those exposure assignments or creating a fear ladder of picking one targeted area that we start to go after OCD in. So again, we start to write down what are all their different obsessions that they have, what are all the resulting compulsions, the situations where that tends to occur. And then we use what we call a thermometer rating. I just have a small one here that I can show you, but really it's just a rating of 1 to 10, where they can rate just how high the anxiety is or what the distress tolerance or what that distress level is if prevented from completing the compulsion. We rate it from 1 to 10. 10 representing maximum distress. Here's the thermometer there. So they use this for each one of their areas of OCD, and this becomes a very important tool as we start to boss back OCD and start to practice some of their exposure steps, because we really use and focus on those numbers, because as I mentioned, 8, 9, 10 is what we call OCD territory. We don't start there. That's too high. They may not gain the success on that first step, and then they feel that it may be too hard. And what's the point of even trying? 1, 2, 3 is a little bit too easy, might cause them some distress, but for the most part, they can push through on that area. But we really focus on those steps between the 4 and the 7, which we call the work zone. And as we start to practice this step, we rate our level of distress every time we practice that step, and we don't move on to the next step until our thermometer rating comes below that 3. And here's how we map it out. So you can see, as I mentioned, some of those different levels. So we know kind of what are the areas that we're starting on that we can choose from. And then it's really neat to be able to take things from the work zone and that they've mastered and move it into their territory, or something that was once in OCD's territory, when we can break it down and move it into the work zone, then that can just be a really helpful visual cue for them to see the successes that they're gaining. So these different tools that we teach, again, I'll go through these a little bit quicker because they are on our website where you can watch a video clip for each one. But we really focus on that cultivating detachment. That's OCD, not me. Really starting to differentiate, that's not your thought. That's the thought that OCD is putting in your head. And just because you think it doesn't mean it's true. And the thought of something isn't the same as doing something. So it really helps them separate out the OCD from themselves. Again, if they have some of these intrusive thoughts that they might be feeling shameful about or scared or bad about, it really helps kind of separate that out. And we even give them a name. You know, what are we going to call OCD moving forward? And there can be some really neat creative names that the kids come up with, from Smugly Wuggly to Mr. Bossy Pants or Worry Pants, or one named OCD Codfish, because their OCD said everything had to be in the right order. So it took OCD and scrambled it and got cod. And so we called, and that was a way to even boss back OCD just in the name. Here's some of the different nicknames: Micromoron, Mastermind, Pest Machine. So again, the more creative they can get, the better. And then that's how we refer to their OCD. So it then becomes, this Mastermind trying to tell you to do something here, or what's Micromoron saying now? You know, and again, that helps really separate out that thought from themselves. We work on the tool on breaking OCD's rules, so doing it differently. So we might do it less, we might do it in a different order, we might delay it. If OCD says I have to do this, if I have to go wash my hands right now, maybe I wait a minute before I'm washing my hands. Or maybe I'm not using soap, or I'm using a wipe. Or if OCD says I have to tap 3 times with my right hand every time I sit down, maybe I'm tapping with my left hand. Or I'm tapping once with my right and twice with my left, or I'm tapping 4 times or 5 times. So any way that we can loosen that grip and power by doing it differently than OCD says, we're starting to get some of that power back. Constructive self-talk, or that think positive, is really important. OCD is that bully that follows them around all day long, telling them negative things all day long. So we want to start talking back to OCD. Some of those positive things, that what you're saying isn't true. I beat you in this area. I'm learning tools. I'm going to get you next time. You're not even telling the truth. And whatever positive statement is going to be that thing that's really helpful for them, we really focus in on, especially when they're in the process of practicing some of that exposure. We use the tool contrived exposures. That's when we boss back OCD when we're strong. So they pick the time and the place that they're going to take on OCD. So they're not waiting for OCD to come to them. They're bringing the fight to OCD. So at this time every day, I'm going to face this and I'm going to use this tool and I'm going to do this. And then we talk about too, there might be times where, you know, if you're not a morning person or you're really rushed and it's really hard, we might not want to take on OCD to start in that time frame, because that might be more of a struggle, and then it might feel like we failed at that. Or if we're not feeling well, or we haven't eaten yet, we're really hungry, maybe getting hangry, let's get something into our bellies and then we take on OCD. Realistic appraisals, show me the proof, similar to what we talked about in the BFRB. Can OCD even prove what he's saying is true? And we literally break it down and look at the evidence. And this is another one where we put it on trial. All right, what is OCD saying is going to happen? Let's start looking at the evidence. Let's gather all of the evidence that says, yes, this is true, all the supporting evidence and all the contrary evidence. And then we must change the thought that OCD is saying if we determine it is in fact a false alarm. This can be a really powerful tool for a lot of people when they say, wait a minute, there's no proof on what they're saying. A what if isn't proof. So that can sometimes be a very powerful tool for some of our youth. Humor is a fantastic one. If we're laughing at OCD, it's a lot harder to be scared. We can't be laughing and scared of it at the same time. And so the more we can make fun of OCD, and we make it very clear, we are never making fun of the child, the youth, or the client, we are making fun of OCD and what OCD is saying. And I've actually seen this one to be a very powerful tool when it comes to intrusive thoughts. Of all things, some people say, well, you never laugh at some of those intrusive thoughts. They're really scary. They can be really intense. And that's exactly what we want to do. And so maybe they're getting some really intrusive pictures that are stuck in their head that are causing them just a lot of fear and anxiety. If we can change up what that picture looks like, maybe now they're dressed in tutus with wigs on, and just make it as silly as we can, or whatever OCD is saying. We sing it to the tune of Jingle Bells, where we say it out loud in an accent, or we make it silly and fun. Then we're laughing at what OCD is saying now, and then we're no longer afraid of what he's saying, because we're realizing, again, that's OCD, not me. And repetition, that thought of repeating that thought over and over again until it starts to sound silly and not mess with you. There's actually a neat app called Bendy Booth, where you can record something that you're saying. So you might record something that OCD is saying. You can record it. It changes it to a funny voice if you want it to. It changes your face and distorts it to be something funny. So it's a neat way to kind of combine those two different tools together, especially if the youth is a little bit too anxious to say the thought out loud themselves. That can be a way to assist with that. Okay, I'm just going to show just an example. So back to Christine, where we watch her do an exposure step. So again, when we think about exposure, once we pick an area that we're working on, we work very closely with the youth to determine the steps that we're going to be taking. It is up to the step, guided, or up to the client, guided by the client, because again, we really need their buy-in. So we don't start with something that's too high, we start low and slow. So sometimes, especially in the beginning, it takes a little bit longer to get up that ladder. But once they do and start to gain momentum, we often find in other areas, it becomes easier for them to boss back OCD in those areas as well.
Hey again, it's me, Christine, the germaphobe. So I'm making this video to keep track of how I'm fighting my OCD. So I've been working with a psychologist for a few months. It's helping. I don't feel so embarrassed anymore and understand it better. It's like my OCD is like a bully trying to push me around and get me to do things. But lately I'm feeling stronger and more in control. It's like my psychologist has been giving me homework or steps to do every day called exposures. It's basically small steps to do to face my fear. It's starting with things that are easier. This week my step is putting my backpack on my bed. So, I know this sounds totally crazy. Putting my backpack on my bed is freaking me out right now, but I know that my backpack is covered with germs. So I'm supposed to sit and look at it on my bed and feel my anxiety and just sit with it. Okay, here I go. I really just want to toss it outside right now. Just gonna sit and wait. I'll be right back. Hi there. It's been about a half an hour. I'm still feeling grossed out, but it's not so bad. At first, my OCD was telling me to take it outside and wash my hands. I was thinking about tonight and not being able to sleep because all the germs seeping into my mattress. But after about 10 minutes, something changed. I realized it was my OCD trying to push me around, and got a lot easier. My psychologist says doing these steps and waiting for my anxiety to go down is the hard part. And I feel it's already working.
So we can see in that video that point where she was reaching that panic peak, right? Where she said, I need a minute. And at that point, she had two choices. She could have given into OCD and said, nope, this is too hard. Put the backpack outside, clean everything up, or choose to sit with that anxiety. And we can see that she was able to stick through that and get over that panic peak. And so the next time she tries that step, because we do the same step over and over again until it becomes easier or boring, the next time she puts the backpack on her bed, it will probably take less time to get over that panic peak. And it will be a little bit easier to do that. And by the time she gets to the 10th, 15th time that she's practicing that step, it will likely be much easier for her to do that. She would reach that habituation much quicker there. And you could hear her some of the tools that she was doing. Oh, that's just my OCD trying to boss me around. So really kind of using that cultivating detachment tool while she was doing her exposures there. I am going to just skip through a couple of these slides. You do have copies of the slides that I provided. Just talks about some of the different studies I've showed. Is ERP effective? And these are some of the outcomes of those, saying, yes, this is how we know this is that gold standard treatment for OCD, because I really want to get to, okay, so now what? How do I get to the Bright Shop if I have a child or know a child that has the body-focused repetitive behaviors, tic disorders, Tourette syndrome, or OCD. Okay, so this is just talking about starting with the ERP, and sometimes that combination with medication can be very effective. Also, on our website, we have another toolbox called the ERP, or Exposure and Response Prevention Toolbox, that also has Dr. Dunk with many different teaching videos and all the different resources that we use within our treatment program. And again, that is open to anybody to watch the videos, look at some of that material, and have some of that education there. Okay, so the criteria for the body-focused repetitive treatment with our clinic, the Bright Shop Clinic at CPRI, is they must have a diagnosis or a query of a diagnosis from a community doctor of trichotillomania or excoriation or one of the BFRB under that category there. Then they must be able to attend or even attend virtually for 9 or 11 weeks, depending on the age of the child. It's either 9 weeks long or teens are 11 weeks. And those are once a week for 60 minutes. They do need to have a mental age of at least 8 years old to be able to participate in the treatment. And they must want to stop the behavior, so they have to recognize this is something that I do want to stop. And all of our treatments require consent from the youth as well to participate in that. And after all of our treatment services, upon completion of whether it's the 9 weeks or the 11 weeks, here we provide a treatment manual. The youth and typically a guardian or a cheerleader attends with them, although some of our older teens may attend on their own, and then we do some individual sessions with the parents. Upon completion of those, each of our treatment services have 2 monthly tune-ups, where we check in a month post-treatment, another month after that, and then all our clients are welcome to have monthly tune-ups for an entire year post-treatment. And they can just request those, and those are scheduled at that time. For access to the CBIT, or the tick management treatment in the break shop, again, they must have a diagnosis or suspected diagnosis of Tourette syndrome or a tick disorder. And the CBIT treatment is 8 weeks long. And that would again be once a month, once a week, for 1 hour with the 2 monthly tune-ups post-treatment. And again, a mental age of 8, but we can go as low as 7, depending on if they are able to really understand the material, must have some insight into their symptoms and at least some symptoms which are ego-dystonic, and that high motivation to engage in the therapy and the treatment. And for the ERP treatment, again, a diagnosis or suspected diagnosis of OCD. And this is a 12-week. And these sessions typically tend to be about 90 minutes, but an hour and a half. For once a week, 12 weeks with the 2 monthly tune-ups, and again, a mental age of at least 8. With that being said, and I didn't have any slides in there too, we also have a program for, it's called family-based therapy for young children with OCD, and that is a treatment, it's an 11-week treatment for youth 5 to 8, ages 5 to 8. So we do have a version of the ERP treatment specifically for the younger youth, where there's a higher emphasis on the scaffolding and cheerleader input, but we do work with the youth as well. But there are more sessions where we're just working with the guardian also. Okay, how do you access them? How do you get to the break shop? That's often the question I get. Okay, now what? How do I get through your door? Do I have to live close by? What can we do? If you live in Ontario, you can access our services. So anybody that has those 3 specific diagnoses, because there's not a place that we can send youth to in most communities to say, okay, you can access ERP here, you can access CBIT here, or the BFRB treatment. That is almost an automatic into the break shop. And so what happens is you can attend either in person or you can attend virtually if you live anywhere in Ontario. So whether you're in Owen Sound, Thunder Bay, north of that, Windsor, Kitchener, Guelph, Hamilton, Sault Ste. Marie, wherever you are in Ontario, if you have those 3 diagnoses and looking for the specific treatments for those, then you can access that through the Break Shop Clinic at CPRI. And so an outpatient referral package is completed by your doctor. So all our referrals coming into CPRI must be completed by a doctor. And as I mentioned, all our services are voluntary, so we do need informed consent from the child or youth or their substitute decision maker where appropriate for every part of our service. So whether the meeting with the doctor, completing a specific treatment with us, and then once an outpatient referral is received through the intake department at CPRI, we work with our community partners to gather that information and the referral to see how to best meet the needs of that client. Some of the communities, outpatient referrals are made through their local single point access community or agencies. So if that's the case, you're welcome to call our CPRI intake department and we can give you more information, kind of walk you through the steps on that. And then the referral form is submitted. I did put the link in there. Actually, I'm not sure if you can put the actual link to the referral package if that's something that was required, but I did put our contact information too if you had any questions. That gets you to our intake department through the email or the phone number that is provided there. So in summary, if you live anywhere in Ontario, you meet the criteria for those different treatments and have the diagnosis of the OCD, BFRB, or Tourette syndrome or tic disorder, you can access the services through the Break Shop Clinic here at CPRI. Once you're into the clinic, there may be some other services that we can support with as well through school consultations or peer-in services to classrooms, those types of things. And that all gets determined at the kind of coming into the garage or that initial service planning that's done with a clinician in the Break Shop when you have your initial doctor assessment. So that's kind of, those are those three specific areas of specialty that we really look at and how you can access. But really, again, just want to stress, if you're anywhere in Ontario, you can absolutely access those treatments. We would mail the manuals to you, to your home, and it can be done either virtually or in person, and sometimes quite creatively. Sometimes we have a youth that joins from a school study with a school support staff, and a parent is joining from work. We're home, so it kind of allows for a little bit more of that flexibility as well. And I think that's all I had there, because I did want to leave room for questions there, because I know some